thank you very much once again for the invitation to present. It's a privilege to participate. Let me tell you, the presenter today is Dr. Suhail. Dr. Suhail has presented before. Dr. Suhail is one of the associate consultants here in Qatar. He is a general surgeon, he's an intensivist, and has been here in Qatar for a long time. The other presenter is Dr. Talat Chagtai. Dr. Talat was born and trained in Canada, and like me, has been here in Qatar for many years. So thank you very much for this opportunity, and we'll let Dr. Suhail start the presentation. So it's a simple case. There's nothing complicated about it, and there will be 3 questions. They are very close together, so prepare to address them. Thank you. Dr. Suhail.
All right. Gary, can we start?
Yes. Go ahead.
All right. Hello, everyone. Greetings from Qatar. We are going to talk about a case of blunt dorsal trauma today. The objectives of the presentation are we want to evaluate the association between the mechanism of the injury and the organs which are injured, and critical decisions about the patient management, whether to do CT scans or take the patient to OR or angiography, and to analyze the management of the complex patient presentation with a patient who has multiple dorsal injuries. We present a case who's a male, 30-year-old, and he was riding an ATV buggy. There was no protective gear. This happened deep in the desert, on the desert dunes around 12:30 in the afternoon. And according to the eyewitnesses, the patient rolled down a slope 5 times before he was ejected and thrown out of that vehicle. Yeah, okay. The sea line is one of the desert points in the country, which is quite vast, and many people who drive into that desert get lost many a times, and there is uncertainty about the slopes, and they are usually in a picnic mode, so they drive fast and they don't know what's across that ledge of sand. Ambulance was called. There was definitely a delay because since there is communication issues also when you're deep into the desert. So ambulance people reached him, and after a delay, and found that he had a GCS of around 14 at that time. There was history of loss of consciousness. On examination, the patient had some tenderness in the spine and was pointing towards his right hip, which was also tender. And according to the EMS notes, the lower extremity neurology could not be ascertained with the surety. So the patient was brought in with the usual spine precautions and a pelvic binder. The vitals as recorded by the EMS personnel was his respiratory rate was fluctuating between 42 to 50 at a point of time and then coming down to 38. The pulse oximetry was showing pure perfusion initially, but on some supplemental oxygen, he saturated to 92%. Heart rate initially 104 and then recorded to be 78 and subsequently 88. While the blood pressure was fluctuating from 102 systolic initially to 85 and at a point of time to 94 also after they resuscitated the patient. So the resuscitation done by the EMS, after they found that the patient was hypotensive, they gave a liter of crystalloid and gave 2 boluses of phenylephrine, 100 micrograms, and tranexamic acid and paracetamol for pain control and hemorrhage control. We received the patient in the trauma resuscitation unit of the Hamad hospital at around 14:41 hours. The patient was ferried by a helicopter. And on initial presentation, we found that the blood pressure was still systolic 90, and the heart rate was not much raised, it was around 90. We gave a further liter of crystalloid, normal saline, and we inserted another line in the left femoral vein, a single lumen IV cannula. And we decided to transfuse him 2 units of packed red blood cells. And after the transfusion and the resuscitation, the blood pressure came up, and we categorized him as an initial responder. Subsequently, the patient drops his blood pressure again. The next reading came down to 72, and the heart rate was around 102 at that point of time. Saturation was 93% on face mask. But by that time, the GCS of the patient had dropped to 12. We saw that there was some blood on the nose. And during the fast examination, we found that it was positive in 3 quadrants, moderate amount of fluid. So the decision was made to intubate the patient RSI using the drugs ketamine, fentanyl, and rock. And we also thought that patient might be a candidate for a SST2 Ribova. So we put in a right femoral arterial line. By this time, the ABG was reported, which showed that the pH was 7.2, lactate was around 4, there was a base deficit of -10, and the hemoglobin was 13. And the Rotum results, which came on later, showed the following results. Dr. Rizoli will talk about the Rotum results.
So my only comments is that most of us who have access to a thromboelastometry, we know that often they are not looked at. What's interesting about this patient is that he has what I would say a mild coagulopathy. So he arrived to us 2 hours after the event in the desert, and we see that on his Rotum, the XTEM CT is normal, the amplitude of the clot is decreased, is reduced, indicating a weak clot, and the lysis is normal. When we look at clot strength, or the A5 or MCF, the question is always, is this platelet or is this fibrinogen? And then we look at FibTem, and then what we see on the FibTem is that the fibrinogen is low. So that A5, that low amplitude, probably indicates a deficit of fibrinogen. It's very well known that patients who arrive hypotensive, most of them have low fibrinogen on arrival, and this case followed the rule. When we measure serum fibrinogen was 1.6, and here in Qatar, the normal is 1.722. So there's a slight reduction in fibrinogen, slight changes in the Rotum. The INR is slightly abnormal, 1.3, and the temperature of the patient is 36.8.
This is the initial chest X-ray of the patient after we intubated him. It shows the tube in place, nothing abnormal in the chest. The bones don't appear to be broken, and the spine appears to be aligned. There is no abnormal cardiovascular presentation on the X-ray. The pelvic X-ray showed that there was a right acetabular fracture, some distortions in the sacrum. Otherwise, the alignment and symmetry was okay, and we can see the 2 femoral cannulas, right-sided femoral arterial sheath and the left side single lumen venous cannula. The urinary catheter brought in clear urine. So from here, the question is what to do next. Do we shift the patient to the CT scan suite, or do we take the patient to the operating room for an exploration laparotomy? And do we involve the interventional radiology for any suspicion of any angiography embolization possibility? Gary?
Yes, sir. Let's go to Atlanta. Dr. Frisbee, your comments, please.
Well, good case. Whether to go to the operating room immediately or not is twofold. Number one, what are his vital signs, and have they been deteriorating as you tried to evaluate him? And what's your clinical thinking about this? What's your gut reaction to it? If you put him in that CAT scanner, how long is it going to take, and is he going to crash on you while you're in there? He's already dropped his pressure twice. I would be hesitant to put him in a CT. I think I'd just go to the operating room. I understand I'm going to get a whole lot of pushback from this, but he does not look very stable to me at this point. So that's my answer. That's all I've got.
Thank you, Dr. Frisbee. Let's go to Bangkok. Dr. Supa.
I agree with Dr. Frisbee. This patient requires laparotomy because he had positive fat and hypotension. And if possible, and if you have access to hybrid OR or C-arm, that would be very helpful for this patient because besides laparotomy and bleeding control in the abdomen, he may also require some kind of interventional radiology procedures like embolization or even rebore at some point. So I agree with Dr. Frisbee to take him to the OR or hybrid room if you have an access to one. Thank you.
Thank you, sir. Philadelphia, Dr. Alex, your comments, please.
I agree with my colleagues. Well, with regards to this patient, so he received 2 units of blood only. I would try to, maximize and activate MTP and, add the, the FFP and the cryo to what he got so far. I think, his chest X-ray looks pretty good, so that's not a contraindication to put a reboa in this patient. If that's the route that you want to go, you can put a zone 1 reboa, and then you can choose to go and do imaging, or you can go to the operating room if you don't have the reboa, or reboa doesn't work, and then you have to keep in mind that he's bleeding from solid organ injury, pretty much anything in the abdominal cavity, but also the pelvis. So you would have to address, those concomitantly. So if I go to the OR and not put a reboa for this patient, I would just try to kind of separate a little bit the incisions and not, decompress a potential pelvic hematoma by just making a big laparotomy. And what I would probably do is just, go below the belly button and just do pelvic packing on each side. And then, up above the belly button and just, kind of pack everything and see how the patient responds to that. If it's not a whole lot of pelvic hematoma, then, and the bleeding is from a, major organ in the abdominal cavity, then, you go with your full laparotomy and take care of, the bleeding source that way. But these are my comments. Thank you.
Thank you, Dr. Alex. Portland, Dr. Kasim? Are you muted, Dr. Kasim?
Good morning.
Good morning.
So, couple of questions before I start yakking away here. It's 5 in the morning here in Portland. I'm barely awake. So, Dr. Suhail, Assalamu alaikum. So, how much resuscitation did you do? You seem to have done, you seem to have deployed everything very quickly. In my hands, putting reboa and high-powered tools like that does take a little bit of time. So did he get adequate resuscitation in the trauma bay?
We actually gave 1 more liter of normal saline after we heard that the EMS had already transfused him. And keeping in view the response to the phenylephrine and the drop in the blood pressure, again, we thought if we overdo the fluid resuscitation, we might land up into more complications. So that's why we decided to give 2 units of packed red blood cells initially in the resuscitation. And he did respond to those resuscitative measures. And thinking about the femoral arterial cath in lieu of the reboa, we actually are trying to be a bit proactive about this measure, because we are trying to use this resuscitative technique more and more in our department. So we are a bit, more tilted more towards inserting a catheter, an arterial catheter to begin with, even if we don't go the complete process. But the arterial line is the initial process which we frequently try to do in such cases.
Okay, so this is what I'm thinking, out in the world, they will not have all these high-tech stuff like you have in Doha. I mean, you have a magnificent super duper center where you can deploy the tools of modern convenience very quickly and rapidly. Well and good. But I think out in the boonies, I don't think we will have that sort of resuscitative equipment available. So I think you need to start thinking like good old days. Is the patient bleeding from the abdominal cavity, or is he bleeding from somewhere else that you have not ascertained yet? Or is it a pelvic bleed? I think you did say the FAST was positive, am I right?
Yes, yes, correct.
FAST was positive. So when you have a patient who has a positive FAST, you have to assume that there is abdominal injury and he's bleeding from the abdominal cavity till proven otherwise. And as you have said many times in these meetings, it takes precedence over anything else. So and patient is in shock, and you have given him somewhat adequate resuscitation. Is it your normal practice to use phenylephrine to resuscitate patient in the trauma bay?
No, no, it was given by the EMS to begin with. So they are the ones who gave the 2 boluses.
Yeah. I think in my hands, I don't do that. And I strongly discourage other people doing that because it gives you a false sense of security. You know, you will get the blood pressure up a little bit and then the patient will crash. So be as it may, I think in this particular case, I will not go to the CT scan like my professor, Dr. Frisbee, has said so many times. CT scan is a patient where the patient goes to die if you're not attentive to the patient. I think in my hands, I think I would go straight to the operating room in a patient who is hypotensive and he has responded somewhat, but he's not maintaining his blood pressure accurately. And I think I would surmise that he is bleeding and I need to stop the bleeding, and the bleeding is most likely coming from the abdominal cavity. Hence, I would go to the operating room first. Thank you.
Thank you, sir. Sao Paulo, Dr. Garcia in Sao Paulo, your comments, please.
Hi, good morning.
Good morning.
Yeah, I agree that if you are in a high resources center, it's different. But if you are in low resources, the best thing to do is to be safe and just take the patient with a positive FAST to the OR, and then in the OR you can decide to do what you're going to do with the pelvic fracture. Another thing is I did not understand if you have placed the Reboa or if you just let the arterial line there so you would be ready for placing the Reboa.
Just inserted the arterial line.
Okay. So and I don't recall how bad is the pelvic fracture.
Clinically, it didn't show any instability, and we can show you the image again.
Okay, it's not that bad. So yeah, one thing I'll probably do if I have a Reboa available would be put the Reboa and then take him to the OR. I think that would be, and I agree with the use of epinephrine. I don't think I would do that also. I did understand that the EMS did that, right?
Yes.
Okay, so because that's probably something that's going to worsen the bleeding, but I'll probably take the patient directly to the OR because I don't have the resources that you guys have in Doha. But I'm really looking forward to see what you guys did.
Mm-hmm. Thank you, Dr. Garcia. Let's stay in Sao Paulo. We'll go to Dr. Ribeiro.
Yeah, thank you. So I do agree with everybody else that just spoke before me. I think I would take this patient to the OR. We have a positive FAST, an unstable patient that arrives with a significant mechanism of trauma. So unfortunately, we don't have this, the stalls to, the Reboa and the C-arc and everything else in the trauma bay. So this patient will resuscitate with blood, activate the protocol, and go straight to the OR. That's what I would do. Thank you.
Thank you, sir. Dr. Untrack, thank you for your patience, sir. Your comments?
Yeah, so I think it's pretty straightforward. I agree with everyone. A couple of comments. Initially, you mentioned CMS found tenderness over the spine. Didn't say where, but obviously need to keep the patient immobilized. The acetabular fracture is looks just slightly displaced. So I would, looking at the odds, I would say it's less likely to be a large pelvic hematoma than solid organ injury with the ATV rolling over the patient 5 times, more likely to be a solid organ injury, ruptured spleen, ruptured liver. This might be in a place like Doha, the exception that proves the rule, but the rule is, you know, he's after resuscitation, his blood pressure dropped again, hypotensive, positive fast, so he's unstable. He should be really in the operating room. But in Doha, they may, for good reason, they may be able to do something a little different. But where I work, in most places, it'd be the operating room.
Thank you, Dr. Tratt. And Dr. Tawari, your comments, please. Thank you for your patience.
Thank you. Like, you know, it is a case of motor vehicular accident, and, you know, it's already been more than 3 hours now. And since after primary resuscitation, like, you know, his blood pressure also dropped to 72/40, and GCS is also dropping. It was 14/12 now, and since his fast scan is positive, so there must be, you know, bleedings from the abdomen. So I think I would also go to OR.
Thank you, Dr. Tawari. I believe everyone, I'm sorry, go ahead.
And that's my, you know, view, but you know, I don't know, because you know, in Doha there might be a good facility where they can try or do something differently, which, you know, I'll be waiting to see further. Thank you.
Thank you very much, sir. Let's go ahead now. If everyone has had a chance to speak once, back to our presenter.
Okay. So nice comments, and they are leading us to the direction in which we also went. We didn't do anything unusual or unexpected. So we went to the OR and we did a laparotomy. The findings were that he had a hemiperitoneum of around 700 ml blood. And we saw that there were lots of lacerations in the solid organs. The liver showed lacerations in the right and the left lobe, but most of them superficial. Only in the inferior surface of the right lobe, we saw that there was a deeper laceration, which was oozy, but nothing you know, extraordinary or actively bleeding. And the spleen also showed multiple superficial lacerations. One of them was towards on the medial side of the spleen, again oozy. Not actually bleeding much. And there were lots of hematomas in different organs. On the lesser side, we saw that the pancreas was having hematomas around the body and the tail. There was a big hematoma in the mesenteric root, but the bowel did not show any discoloration. The retroperitoneum on the left side in zone 2 showed a big hematoma, and the transverse colon splenic fracture and the descending colon showed multiple hematomas. The patient was maintaining his blood pressure in the OR, and so after the laparotomy, we saw these findings. Now, what do we do? Gary?
Go back, control the findings. So the idea is here, like if you're, very quickly, and if you're the surgeon, what would you do? You find a lot of blood, liver lac, splenic lac, and hematomas. What would you do for each one of them?
Sandro, hi, this is Marcelo. Let me ask you a question. How was the patient during the procedure? Was the patient stable, or was still?
No, he was stable. He had stabilized and did not show any drop of the blood pressure any further.
Okay.
So actually, it's interesting because this patient had massive transfusion protocol activated, and in the OR, the massive transfusion protocol is deactivated. They felt that the patient was doing well.
Okay, we ready for more comments? Dr. Rizoli?
Yes, please. And we can just ask maybe one or two colleagues. I don't think there's anything.
Okay, very good. Let's go back to Sao Paulo, Dr. Ribeiro.
Yeah, okay. I would probably just remove the spleen and just get it done. And I would not touch the hematomas unless there was something else going on. I would just leave them over there as far as I would be sure that everything else was under control. And probably I would just remove the spleen and finish the procedure.
Thank you, sir. Sarasota, Dr. Lujack.
Yeah, so yeah, I agree. The spleen, the safe thing to do is remove it in a 30-year-old. If it were an isolated splenic injury, then you could consider splenorrhaphy, and perhaps, and not being there, perhaps the doctors in Qatar in the operating room might have looked at the whole situation and said, well, this is the exception that proves the rule. They may try to do a splenorrhaphy, save the spleen, or partial splenectomy. That would be okay as well. I would really look very carefully at the pancreas, at least leave a drain. And, you know, the hematomas in the body and the tail, I would, you know, probably try to clear them away. And then the hematomas in the colon, just be sure that it's not going to result in a leak later, that if they're superficial, fine. If you can unroof them and imbricate the serosa, fine. You know, but just explore very carefully at the root of the mesentery, especially around the pancreas, which is where the problems can occur, and at least drain there. And otherwise, I think it's pretty straightforward.
Thank you, sir. Dr. Frisbee, Atlanta.
Yeah, I agree. I have an interest. I have a interest in this right liver lac. You said it's oozing. Would you consider putting a tongue of momentum in there and just tacking it up? That's what I would do. I think the remainder of the comments is right. I don't think you go mucking about in a bunch of hematomas. You're just going to create more trouble, and then it's going to be quicksand. I'm a little concerned about the mesenteric root. As long as the hematoma is not expanding, I think I might, you know, I'll just leave it alone. But it would be a real temptation to make sure that that one wasn't any problem. That's all I have.
All right, thank you, Dr. Frisbee. Dr. Alex, your comments, please.
A lot of findings and not a whole lot of blood in the peritoneal cavity. So with the liver, I would just pack the liver and try to do hemostasis, as you know everybody else has mentioned. The spleen, probably, you know, remove it, but again, there might be an exception, and maybe the team over there may decide that this may be the one spleen in a few thousands that may warrant splenorrhaphy. I would not mess with the pancreas at this time, even though it has a hematoma. The hematoma, also the root of the mesentery, is a little bit concerning, and also the one in the zone 2 on the left. If it's not expanding, I would not go and explore that. And then for the colon and the splenic flexure, again, you have to see how much, you know, devascularization you have, if it warrants resection or not, which at this point it may be hard to say or to tell. So what I would do, I would consider imaging at this time. You know, don't close the abdomen, just pack the liver, image and see if there's any active blush in the liver that may warrant, you know, embolization, and then go to the TQ, continue resuscitation, and then plan a return to the OR for possible bowel resection and closure, or addressing any other concerning findings they may see on imaging. Thank you.
Thank you, Dr. Alex. Dr. Super, Bangkok.
Considering the injuries and physiologic derangement he had at this point, I agree with a damage control surgery for this patient, even though his vital signs seem to be stable in the OR at the moment. For the liver, I agree with packing first, but you can also try to do Pringle maneuver and try to selectively control the bleeding. Once you know whether it was artery or a venous bleeding, you can try to Pringle and try to maybe selectively suturing the injury. For the spleen, I would pat it first. And for the hematomas, like everybody else mentioned, zone 2 not expanding doesn't require exploration. But for me, pancreatic body and tail, that would be zone 1. And I would explore that hematoma. And if the patient had like a pancreatic transection, I would perform a quick distal pancreectomy and splenectomy altogether. For mesenteric root, if the bowel viability is good and it's not expanding, I wouldn't explore it at this point. So in summary, I would pat the liver, try to do some hepatography and pack it, and explore the pancreatic hematoma. If he had pancreatic injury, I would perform distal pancreectomy with splenectomy, and then temporary abdominal closure and plan for a second operation once he's better resuscitated. Thank you.
Thank you, Dr. Super. Dr. Tawari?
In this one, I just want to do the packing of the liver, and for spleen, like, may I know how deep was the laceration, like,
Multiple superficial lacerations. The one on the medial, they were on the lateral aspect. The one in the medial was a little bit deep, but slight ooze, not actively bleeding.
Okay, and that means there is 5 to 8 centimeter laceration. Not it's like 5 plus 7 to 8.
No, it's 5 centimeter and 7 to 8 centimeters. These are different lacerations.
Okay, so for me, if there is no active and in the middle, like, if it is not the short gastric vessel, so I think I'll also go for packing. But I'm worried about this pancreatic body and tail and mesenteric root. I'll just explore that one. And anyway, because we are not going to close that one, so I think after cleaning that one and packing that liver and his spleen, I'll just leave it, so that because we won't be closing the skin, we'll just leave it. So I think I'll go for packing, that kind of thing. Thank you.
Thank you very much. Sao Paulo, Dr. Garcia.
I'll just do the splenectomy and drain the pancreas. I think and hemostasis on the liver, and that's it.
Thank you, sir. Dr. Qasim, thank you for your patience, sir. Your comments, please.
Thank you, Gary.
Yes, sir.
There's a very famous saying, don't poke at the tiger because it'll bite back. And I think when I opened this particular abdomen, I think I'm looking at the tiger there. So it is very tempting, like Professor Frisbee says, to go and muck around. And I think I would try to avoid that temptation as much as possible. So let's take a couple of things here. What would be the main reason that I arrived in the operating room for this particular gentleman? I thought that I was bleeding significantly, but there's not a lot of blood in the abdomen that I can see. So blood must be hiding somewhere. So I would keep that in mind. So what can I do immediately to get the patient stabilized so I can get him back to the ICU to do secondary resuscitation in the ICU later on if he is not very stable? But you tell me that he's very stable in the operating room. So I will try to do as little as possible in this particular case at this moment. And I agree with Dr. Supa. I would deploy the damage control and spleen. It is not a very significant injury at this moment. And I could easily wrap it with whatever I want to wrap it with to stop the bleed. And the pancreatic injury does not need immediate treatment, but I would be cognizant of the fact that I may have to return here later on. And the rest of the stuff, which is hematomas here and there, I would try to avoid the temptation of poking into it at this moment. And I would do as little as possible in the operating room in this particular case, knowing that I'm going to be coming back here. And I would lavage it to not put any drains anywhere at this moment, and do the minimum surgery in resuscitation and take him back to the operating room with a view to coming back in 48 hours to have a look at it again. That's what I would do. Thank you.
Thank you, Dr. Qasim. Let's go back to our team in Doha so we can continue.
Now the decision, the further details will be discussed by Dr. Talat. Yeah. Okay. We have discussed that.
Hi, Dr. Talat here. So what we decided to do is, of course, initially we did packing of all quadrants. I checked with anesthesia that the patient was stable. And because he was stable, we removed the packs and sort of looked around. So the liver and spleen lacerations were there. They were oozing. But we felt like we could approach them and do hemostasis using Surgicel, using gel foam, using cautery. So we did not do a splenectomy. We repaired the liver and the spleen. As for we didn't touch the zone 2 hematoma on the left side. And we also looked at the pancreas, tail, and hematoma, and we decided to leave that alone. Then we ran the bowel. And when we ran the bowel, of course, the mesenteric hematoma was a concern. Sorry. So you can see here what we did with the liver. For the retroperitoneal hematoma, we decided to not approach it. And the transverse colon, the only thing we found upon running the bowel was the hematoma in the transverse colon, which we decided to explore. And when we explored that, we found that there was a perforation of the transverse colon, about 1.5 centimeters, about 1 to 2 centimeters, which we decided to primarily repair. Then ran the rest of the bowel, was fine, and we decided the patient was stable. We had no more bleeding. We actually decided to close the abdomen.
And by that time, the pH intra-op had also shown changes. The pH was 7.39, lactate had come down to 2.4, base excess to -3. Hemoglobin was 11, INR still 1.3, and a rotum, which was done intraoperatively, showed the following findings.
So again, the only reason here is just to emphasize also the physiological side of managing bleeding patients. So it's not quite clear to us, but we think that the patient was given some fibrinogen. But then when you look at the Rotum, you still see that the clot amplitude, the A5, it's still not normal. So even though the patient got a few grams of fibrinogen concentrate, we see that it's still slightly abnormal. And now what we see that's new, we see the CT. So the CT is the measurement of clotting factors. So now the CT is prolonged. So the CT is becoming longer. So I don't know exactly how much water was given to the patient intra-op. I know that no blood was given during the whole operation. I know that some fibrinogen was given, probably not enough. And now I see a second coagulation problem that might be, that could be corrected if the patient had received the plasma. Again, interesting, the MTP was activated initially and then was canceled once the patient got into the OR. Yeah, no major disturbance in here, but some things abnormal. And I always find that if the Rotum is abnormal, it usually indicates that there is some bleeding still going, despite all the other numbers moving towards normal.
So after finishing the surgery, we decided to close the abdomen primarily, and then the decision was to either shift the patient to the TICU for post-op care or complete the CT scan, which we never did, and IR probably depending on the radiology. So, So we decided to take the patient for a pan-CT scan on the way to the trauma intensive care unit. And what we find is that the liver shows the same lacerations which we saw intra-op and intraparenchymal hematomas, but there is an active contrast blush deep in the substance of the liver, and the splenic lacerations also present, not deep enough, with the minimal blush, again intraparenchymal, which we could not ascertain from the outside. The left kidney showed laceration and a big hematoma involving the superior pole of the kidney. The left adrenal gland was all, it was encased by that hematoma. And the spine showed that he had a displaced body fracture of the C6 vertebra and a compression fracture of the T7 body. And the pelvis showed pelvic right vestibular fracture, inferior pubic ramus, and the sacrum. Not a big pelvic hematoma, not a significant hematoma there.
Let me just ask you, Dr. Talat, that described the operation. When you explore the pancreas, did you find any parenchymal injury to the pancreas, and how large was the retroperitoneal hematoma in the pelvis?
Yeah, so the hematoma in the pelvis, to answer the last part, was not that large. The zone 2 hematoma, going from the pancreas and lateral, was moderate size, I would say. It was not expanding, but it was moderate size. And the tail of the pancreas was obviously seemed like there was a hematoma there, but to us did not seem like it was something worth exploring and leaving a drain. We thought about leaving a drain, but we decided that it wasn't significant enough to do that.
And there were no lacerations on the body of the pancreas, just a simple hematoma.
Yeah.
Yeah. These are the images of the C-spine. We can see the C6 vertebra body fracture. I don't know whether you can see the cursor on that.
Yeah.
Okay. This is the actual view of the abdomen, which shows the blush in the liver. And this blood had accumulated in the post-op period. Coronal view of the blush with a big intraparenchymal hematoma of the liver. Little bit of hematoma on the left side. Another image of the parenchymal hematoma and the tail of the pancreas, hilum of the spleen area with a hematoma. And this is the kidney which has encased the superior pole and the adrenal gland. And again, we can see the blush on that right lobe of liver. The splenic blush was not that significant, and it was again deep-seated within the parenchyma. And these are the lacerations which we did not actually appreciate from the outer surface because they appeared to be very linear, very thin. This is the pelvic fracture, right acetylum. And the patient was taken to the IR suite for embolization of these vessels, which showed the blush. And the IR embolized the hepatic artery and the splenic artery. These are the images which are taken 2-3 days after the embolization was done. They used coils, they used gel foam. And this is the follow-up MRI of that patient for the C-spine injury, and they decided on operating upon this patient. They did an anterior cervical discectomy and fusion. This was the fixation of the pelvis with recon plates and nails. So some points of discussion regarding the management of the patient right from the resuscitation part to the OR part. So if we would have decided the patient goes to the CT suite rather than the OR after the resuscitation in the trauma room, the possibilities of the patient going to the IR would have been high because of those evident blushes in 2 solid organs. And the chances of finding that bowel injury would have been least because it's otherwise also difficult to pick up bowel injury. So we feel retrospectively that if the patient would have gone to the CT scan, he would have been transferred to the IR suite for an angioembolization, and this bowel injury might have presented later in his course and might have led to morbidity, secondary peritonitis, and all the complications that have followed that missed injury. And on the second part, if we would have taken him to the OR like we did and then not complete the pan-CT scan, then we would have missed a whole lot of injuries and the active bleeding and the need for transfusions in the post-op care and lots of mind-boggling things for us to discuss about the further management of this patient. So luckily that we did the pan-CT scan, and besides the bleeding, we did find the spine injuries which needed active surgical intervention. The mild coagulopathy, which we saw on the Rotum, we need to correct that, because that, if significant, might prolong the blood loss, and again the patient would have been dependent on transfusions and the complications associated with that. The last thing which we want to say is that if we would have thought of packing the abdomen and then going for the CT scan and then picking up those injuries and the patient going to the IR, we have discussed this many times with the radiologists. The comments coming from that side is that the packs, though they don't per se cause any issues, but the radio opaque markers on those packs do hamper their intervention because of creation of artifacts. That's the first thing. And the second thing, if we too tightly pack the abdomen, then sometimes it does become difficult technically for them to negotiate the vessels and embolize them. So in those situations, they might have to embolize more proximally and cause more necrosis than would have been needed. Yeah,
I'll just make a few comments here. I think that the points brought up by Dr. Suhail are great. The one is that no one thought this patient would have a colonic injury. It was just because the surgeon in the intra-op said this bowel doesn't look right, and there was not a drop of feces, there was no evidence of gas, there was only blood in the cavity, and still when the surgeon explored the hematoma on the wall of the colon, he found a perforation that could be, I suspect, easily missed by the CT scan. And then the last thing is the number 3, is that this patient had an abnormal Rotum. So even though it's mild, it is not big. Usually, if you have something abnormal in the Rotum, this patient is bleeding. And this patient was still bleeding, even though everybody left the OR. They were giving high fives to everybody and say, look, we saved the spleen and we didn't pack this abdomen. We're not gonna have to come back and do a second look. Look what a great work. It was correct to still go to CT, and they found this big bleeds, right? They're not discrete bleeds. So I suspect had this patient not gone to embolization, he would be one of those patients that would be in the ICU, and in the middle of the night after getting a lot of transfusion, someone would say there's something wrong, and this patient could be all of a sudden be taken back to the OR with a belly full of blood and with lots of unnecessary blood transfusion. So I think that part of the excellent post-operative recovery of this patient was because I think every step was followed.
So in the end, the patient was initially taken to the TICU. He was managed there for a couple of days. And after successful management, he was transferred to the step-down unit. And from the step-down unit, he finally went to the ward and was successfully discharged in a stable condition on the 19th day of his injury. Any comments, Gary?
Yes, sir. Dr. Alex in Philadelphia, your final comments, please.
Thank you for presenting and sharing this case with us. It's always excellent and nice to learn from each other. I think you had a great outcome. With there are different ways in approaching a trauma patient that is also based on what the resources are available. I think it's important to know what limitations each step that you're taking has and what you can possibly miss, and keep that in mind. I think, with the Reboa, probably less blood loss, whether you go straight to the OR with the Reboa in place or you go to interventional radiology, and maybe that may have helped with the coagulopathy. But it was excellent and a great care, and yeah, that colonic injury could have been missed if he would have been just imaged. But with an open belly, come back the next day, maybe would have looked different. But it was excellent. The only question I have is with the C6 fracture. Did he have any? Was there any concern or a workup to rule out blunt cerebrovascular injury?
Yes, we when we saw the images in the post-op care, we usually have this, low threshold for doing the CT neck angio, particularly in shock patients and those categorized with trauma T1 patients.
So he had.
Thank you so much.
Yeah.
Thank you.
Thank you, Dr. Alex. Dr. Garcia in Sao Paulo, your final comments, sir.
Congratulations, a great case. I think that, as Dr. Rizoli said, the thing that made a difference with this patient is that he was able to get a CT scan after the first surgery. So as the damage control resuscitation was very well done, the patient was stable enough after the first surgery to go to the CT scan, and so you saw the blush on the liver. Because if the patient had gone through a damage control procedure and with an open belly and went to the ICU, you would have missed the arterial bleeding, probably in the second time too. So the good thing is that the patient was stable enough to see the arterial bleeding, and then it was controlled by radiologic intervention. Congratulations on the case.
Thank you, Dr. Garcia. Let's go to Portland. Dr. Kasim, your final comment, sir?
I have a question for Professor Rizoli. Is it not true that the patients who arrive in the operating room from major trauma like this, they are all coagulopathic?
Yeah, Dr. Kasim, let me say, right, that even though it's 5 a.m. there in Portland, your brain is as sharp as usual. Yes, they do, and that's for me. It indicates that some organs or systems, they don't work appropriately, and one of them is the hemostatic response. And sometimes just by correcting the bleeding alone, the hemostasis also corrects itself appropriately. But for me, the thing here is that it shows that this patient was still bleeding, even though it looked fantastic, and all the other numbers were great.
So you would say the bleeding is significant enough that we should think about it at least, or deploy the Rotum and other modern equipment that we have available in most cases. Is that what you're saying?
Yes, Dr. Kasim, but there are many studies that show that Rotum tag make no difference in the outcome. But I think that you could say the same thing about hemoglobin, right? This is a lab test, right? So it's hard to believe that a lab test will affect the mortality. But I think that the more information you get, better your decisions are. So I find that Rotum often helps you in making some critical decisions.
Thank you. So my comment on this case is, like Dr. Talat Chaktai has mentioned, he's a fabulous surgeon, by the way. You will see his work on YouTube all the time, and I watch it very diligently.
Oh, thank you. It's a long time.
He's as astute as it comes, and even his dad was a fabulous surgeon too, by the way. So when you have a surgeon of that caliber, they can look at the colon and say, this is what it is. This is going to be a hidden tiger. I need to poke at this and have a look at it. And of course, he was able to find the hole in the colon and fix it. But if we would have followed the outline Dr. Supas was telling us to do, which is damage control surgery, do the minimum and go back and have a look at it. I think that is another way of treating this case as well. But when you have the resources available, as they have in Doha, excellent physician, excellent unit, and facilities where they have every equipment available, then the outcome is going to be really good, like this fellow has. It's a very good case, and I learned quite a bit from Dr. Rizoli this morning. Thank you. I'm glad I got up at 5.
Thanks for the nice comment. One thing that's interesting is if this patient would have come with a head injury and the GCS initially was 8 or less, would we have stayed a little longer to stabilize him in order to go to scan first? This is the thing that may have changed what we did. And we're lucky he came in with GCS 14, so we weren't that concerned about a head injury. That helped us say, let's go to the OR. Yep.
Thank you, gentlemen. Let's go to Dr. Frisbee for his final comments in Atlanta.
Well, it was a very, very good case. The only comment I have is a word of appreciation to Dr. Rizoli. You know, I'm a little bit older than Dirk, and as a result, you know, when you hear about the Rotum, in my mind, all I think about is, oh God, another lab test. So I'm very, very appreciative of the explanation you gave for each one of those and how it relates to the patient at hand. It was very, 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 very resourceful, and thanks again for that. As far as the case, you know, when you get in a belly that's just got all these hematomas, you need to remember one thing: the enemy of good is better. And as a result, if as long as they're not expanding, you probably are smart enough to know that just to leave alone. I think I probably would have packed them and come back in a couple of days and looked them over just so I could sleep at night. But I want to thank you for the case. It was very, very informative. Did a great job.
Thank you, Dr. Frisbee. Let's go to Dr. Tewari for your final comments, please.
Very interesting case, and you know, trust me, I learned a lot actually. Like, you know, for that post OR CT scan, which really identified so much, and I think that also saved the patient. So thank you, and hats up to the team who managed this case. Thank you.
Thank you very much for your comments, sir. Let's go for final comments. Let's go back to Sao Paulo, Dr. Ribeiro.
Okay, thank you very much for this beautiful presentation. I also learned a lot. I think one of the lessons we have to keep in mind here is like the patients where you're deciding to do a kind of a final procedure, like closing the belly, is that you have to make sure everything else is under control, and then the CT scan plays a very important role. I would probably manage this patient with an open abdomen, just go back 1 or 2 days later to make sure everything is fine. But once you decide to do a final procedure during the splenectomy and closing the belly, I think is extremely important to keep in mind, especially when you have a lot of hematomas all over the belly, to try to check it out and make sure by the CT scan everything else is okay. So I congratulate your team, Dr. Rizoli. Amazing work, and very nice to see you all. Thank you very much.
Thank you, Dr. Ribeiro. Let's see, is our friend in Bangkok still with us? Bangkok, Dr. Super, there he is. Your final comments.
Thank you, Dr. Rizoli and the team for presenting this case. We learned a lot as usual. In my hospital, if we decided to pack the liver like this, before we remove the packing, I always send the patient for angiography with possible embolization of the liver, with or without a CT scan, because when you just remove the packing without embolization, we experience rebleeding and we had to repack the patient. So in the hospital, once we pack the liver, with or without a post-operative CT scan, we usually send the patient for angiography and possible embolization. And in my experience, the packing does not interfere much with the IR procedure. Thank you very much for presenting your point of view, and we learned a lot.
Thank you.
So, Dr. Untrack, thank you for your patience, sir. You ought to know we wouldn't forget about you. How about
yes,
your comment?
no, I knew that.
Okay.
Very, very instructive case. A lot of things to think about. Those questions that you raised at the end were very, very good to think about. And I think that indicates that, you know, anyone who would have operated initially on this patient, and most of us would have, post-op would have done the CT scan, and based on if a CT scan were done initially, the presence of all those hematomas would have been an indication for a laparotomy after the patient was stable for that reason. Secondly, you know, there are a lot of judgment calls in this case, whether to explore a hematoma, not explore, leave it drained by the pancreas or not. There's no no substitute for actually being there, and it's really, you got to give credibility to the surgeon who actually was there, saw, and made the best judgment. I think in this case it worked out beautifully. Question about the Rotum. You know, after seeing those results, Dr. Rizoli, I was just wondering, since the patient already had 2 units of packed cells, why those results didn't prompt you to give a couple of units of fresh frozen plasma in addition to the TXA that he already received, just to correct those abnormal findings.
So what he got was a fibrinogen concentrate, and I think that there is very good evidence that fibrinogen is probably the earliest coagulation factor to drop dramatically, and there's despite no evidence that giving fibrinogen makes a difference in outcome. It makes good biological rationale that you should correct it if you want the patient to have a better outcome.
Mm-hmm.
Great, thank you.
Okay, before I turn it over to Dr. Martos, let us check to see if he is still with us. Yes, he's there. Do we have any final comments before we turn to Dr. Martos to close us out? Okay, so Dr. Martos, go ahead and close us out, please.
Yes, we had another great case from Hamad Hospital. As usual, they have interesting case, a lot of discussions. They have a lot of technology available. But this case shows sometimes we need to wait a little bit, do the regular surgery, and then go further to find out what's happening. Excellent case, Dr. Rizoli, as usual. And Dr. Rizoli is well known, is famous. He dedicated most of his career of studying coagulopathy. And when he discussed about Rotum, TAG, etc., we always learn a lot. I hope we can see you at the Panamerican Congress, Dr. Rizoli, and for sure we're gonna talk about this. Keep teaching us. Next week you're gonna looking for a presenter. In 2 weeks we're gonna have Dr. Suprek from Thailand presenting. Please contact Valeria to submit your dates for present your interesting case, everybody. Thank you, everybody. Remember, this Wednesday we're gonna have the Miami 6 p.m. the monthly Panamerican Society case reviews and gathering discussions. I'm going to have a great case presentation, and if you can, please join. Okay. Thank you very much. See you all next week.
Thank you.
Obrigado.
See you all. Awesome. Sure.